Morning, everyone. We are now live.
Good morning, everyone, and welcome to this meeting of the Primary Care Access Delivery and Payment Task Force. I'm David Seltz, Executive Director at the Health Policy Commission, and honored to serve as co-chair to this Primary Care Task Force. Thank you to all of the members of the task force, our 25-member strong Primary Care Task Force for participating today in this virtual meeting. We have a really, I think, full and engaging agenda planned for today, and really excited to have a guest presentation from Chris Kohler, who's the president of the Milbank Memorial Fund, and someone who I think is well known to many of you on this call and to many of us here in Massachusetts. Welcome as well to all of the members of the public and interested stakeholders who are watching this meeting on the live stream. All of the materials for this meeting are posted on the HPC's website, and available after the meeting will be a video of this meeting as well. So since our last full task force meeting, we have launched two additional work groups of the task force who met for the first time. Both of those work groups, first a data and research work group, and secondly a workforce work group, had their first meetings to begin to be able to deliberate with a little bit more focus on some of the key deliverables of this task force. As we reviewed at our last meeting, the legislature in this statute lays out a number of very specific deliverables for this task force to produce on a staggered timeline. The first deliverables due as soon as this September, with the final deliverables due next May. So we felt it was really an opportunity to be able to have some work groups that could dive a little bit deeper into the issues around some of these deliverables. And so today we're going to start the meeting with just a little bit of a recap from those two meetings so that the full task force is aware of those conversations, has an opportunity to provide additional commentary and ask questions. And then after those recaps and discussion, as I said, excited to have a presentation from Chris Kohler, who's going to be really focusing on this concept of primary care spending targets and lessons learned from Rhode Island and other states about how best that policy can be used to improve and strengthen primary care. But before we dive into our first matter of business, which will be the approval of the minutes, I'd love to turn it over to my co-chair, Dr. Mahania, for some opening remarks as well.
Thank you, David. I'm always hesitant to go after David because he has such an amazing speaking voice. I always feel like a little kid after speaking after him. So welcome to all the members. Thank you again for the time that you're taking to participate in this. I think that very few remarks. I just wanted to say that I've been quite impressed and taken by the passion that members have exhibited, both in the main task force meeting, but also in our work groups, but also like the amount of content expertise that is present in this group, but also the degree of lived experience. Both of those have been really impressive. The breadth of discussion has also been somewhat of a surprise to me, just like how many ideas and how many concepts are coming through. So I'm very excited, and I'm very hopeful that we will be able to come up with recommendations and ideas that actually have a good probability of making it through the political decision-making process. So I'm very excited. And I'm also very excited to hear from Chris Kohler. I'm a big admirer of the Milbank Memorial Fund, and so I look forward to what he has to say. I hope that he'll remember that this is a public event and it's live streamed, so I have to make sure that he doesn't use his incisive sense of humor. But welcome, Chris, and I'll turn it back to you, David.
Thank you, Kiame. And I too just want to reflect a sense of gratitude for the incredible commitment and contributions that have been made to this task force so far. I mentioned this at our workforce work group meeting, which occurred right after a really tremendous health equity summit, um, which was organized by the Health Equity Compact and included a specific panel on primary care and the importance of primary care in advancing health equity. And in the course of that, I thought really, really wonderful conversation and event, the governor, Healy, also in her remarks specifically mentioned this primary care task force and how excited and encouraged she was by the opportunity of us being able to meet together and to develop recommendations, and how she's looking forward to our deliverables and outputs from this work. So yet another testament to the importance of this challenge and ambitious agenda that we have in front of us. So we do have a matter of business as a public body, and that includes approval of minutes from the last full task force meeting. So because we're doing this virtually, I am going to have to call the roll, and every member will be asked, please state yay or nay to approve the minutes. And if you were not at the last meeting, you can feel free to abstain from casting a vote. I do know that we have at least one suggestion for a correction. But first, let me just get a motion to consider this vote and the minutes.
This is Christina Severin, so moved.
Thank you. With that first motion, are there any members who wish to offer commentary or changes to the minutes?
Yes,
Go
I
ahead,
do.
Barbara.
Thanks. So in reading the minutes, I found a sentence at the very end that was sort of describing the discussion of the task force. And I felt it was a little misleading because it mentioned that members discussed the adequacy of the Commonwealth's current investment in primary care, and then went on to state another thing. And so I just felt it's important for somebody reading this to really convey the feelings and the argument in the room, which is we're in an grossly inadequate situation when it comes to primary care. So I think it was just a wording issue, but I think it makes a difference, and I'd like to change the wording of that sentence. And I can propose a substitute sentence if that's useful.
Please.
Okay, I'll just put it in the chat.
So I'll read this out loud so members of the public can hear this too. Members discuss the inadequacy of the Commonwealth's current investment in primary care, including lack of equitable reimbursements for all provider types and payment models for team-based care, the declining rate of spending growth, and the increasing burden of healthcare costs on taxpayers, employers, and employees. To me, that reflects very well the tone and tenor of the conversation. So thank you, Barbara. Seeing if there are any objections to that change. If not, I will entertain a second motion on the minutes as amended.
I make a motion
Second,
to accept the minutes as amended.
second, this is Barbara Spivak.
Great, thank you so much. All right, so we'll now, if we can advance, this is the vote for approval of the minutes. If we advance one slide, we can see all of our members, and again, just ask for a yay or a nay. So Dr. Mahania?
Yeah.
Is Senator Friedman with us?
Yes.
Hi.
Yes. Hi.
Thank you.
Hi. Yes.
Representative John Lawn?
Yes.
Thank you. Commissioner Mike Caljo?
Yes.
Executive Director Lauren Peters?
Yes.
Dr. Ryan Schwartz?
Yes.
Dr. Altman?
I'm voting on the minutes.
Yes.
Yes.
Thank you. Laura Black?
She's not here, David.
Yes.
No,
I'm
she's here.
I'm here.
She's
Can you hear
here.
me? I'm here.
Yes.
Yes.
Thank you. Thank you. Thank you. Jennifer Blewett,
Yes.
Oh, Shira, thank you.
Allison Bracken.
Yes.
Thank you. Dr. Critchlow.
Yes.
Thank you. Suzanne Curry.
Yes.
Thank you. Dr. Dixon.
Yes.
Thank you. Dr. Friedberg.
Yes.
Thank you. Dr. Gilchrist.
Yes.
Thank you. John Hurst.
Yes.
Thanks, John. Dr. Martin.
Yes.
Thank you. Dr. Mellon.
Yes.
Thank you. Sarah Mills.
Yes.
Laura Pellegrini.
Yes.
Thank you. Dr. Pring.
Yay.
Barbara Rapson.
Yes.
Christina Severin.
yes,
And Dr. Barbara Spivak.
Yes, approve.
Thank you. And I also vote yay to approve. Thank you all. With 25 members of this task force, it may take us, a full meeting to approve these minutes every time, but I promise you we'll get speedier at doing this as we continue this work. So diving right into our agenda for today, we're going to just do a little bit of a recap of the 2 work group meetings before we turn to our guest presentation. So I will be providing just a short readout of the data and research work group, and Dr. Mahania will be doing a readout of the workforce work group. So just as a reminder, we set up these work groups really, as I said, as an opportunity to have additional time and deliberation on these topics. But ultimately, we do envision that the final deliverables and recommendations will be brought back to this full task force for consideration. And so we have no deliverables under consideration here today. But for this first data and research work group, we focused on 3 specific deliverables that were set forth in the statute. Defining primary care services, codes, and providers for the purposes of measuring primary care spending and setting a spending target, developing a standard set of data and reporting requirements for private and public payers, providers, and provider organizations, and finally, to assess the impact of health plan design on health equity and patient access to primary care services. So at this first meeting, we really focused on that first charge and deliverable, which was around defining primary care services for the purposes of measuring spending. And so as such, we really focused our work group meeting on a presentation from our colleagues at the Center for Health Information and Analysis on their current process and methodology for defining primary care and measuring primary care spending, which they've been doing for the last few years. I thought overall this existing process and framework was well received by members of the task force, but certainly there was a lot of questions and discussion throughout the presentation. I want to shout out Lauren Peters and Caitlin Sullivan from CHIA, who I thought did an absolutely excellent job walking through the complexities of this process. So CHIA's methodology is developed, includes a pretty broad and inclusive definition of primary care, but it can be adapted and adjusted based on our analytic need or analytic question. The data is collected at a summary level from essentially all commercial payers, Mass Health, Medicare Advantage, and represents most Massachusetts residents. This data collection allows for the ability to stratify by insurance category, payer and provider type, provider organization, service category, and also to understand the difference in member cost sharing versus payer cost sharing. And the payers allocate claims to primary care spending based on a set of primary care service codes and services that CHIA has developed, provided by a primary care provider type. And these primary care service categories include both claims-based and non-claims-based categories, as you can see listed on the right-hand side of this slide. And then the provider types include a range of different providers, including physicians, family medicine, internal medicine, pediatrics, general practice, adolescent medicine, geriatric medicine, obstetrics and OBGYN, other providers, including nurse practitioners, physician assistants, community health center workers, community health nurse specialists, midwives, and women's health clinics. This process has been developed and is something where there is a capability and an opportunity to evolve and to change, to add in new provider types or new provider codes. And so in that way, it can be flexible depending on the evolving infrastructure and face of primary care. Christina Severin would love, please jump in with comments and questions as I go through this.
Thank you, David. I just wanted to make a comment in the last bullet where it says Community Health Center /FQHC. I think it's worth noting that FQHCs really need to be differentiated. They can't be grouped in with something that's called Community Health Center. Community Health Center is a relatively generic term. There are outpatient hospital clinics that brand themselves community health centers. There's nothing wrong with that. However, they are not FQHCs as a provider type. FQHCs are in a different class. They're a 330 grant recipients through HRSA. And the way that they are reimbursed is also distinctly different, where they are paid a PPS, a protective payment system. And so I would not group the generic term community health center with the very distinct term FQHC.
Thank you, Christina. And I will admit, I don't know exactly in the data if it is all lumped together, or if it is essentially two categories, but that's something I take your point and we'll look into that. I don't know exactly.
If it is lumped together, we'll need to go through the work of unlumping them because they're quite different.
Yeah, understood. Understood.
And David, just to add on to that, we do distinguish in the codes. So I think this is just shorthand.
Great. Thanks for chiming in, Lauren. And so, Christina, sounds like the structure allows us to look at that separately. So on the next slide, after talking through the CHIA process and how they collect and analyze primary care spending, we also just wanted to reflect that the Health Policy Commission also has a process where we use claims data to also be able to look at primary care spending. Because we're using claims data solely, we do not have that ability to look at non-claims parts of primary care spending. And so it is a little bit different than the CHIA process. But I think of it as complementary and an ability for us to use the claims data to ask different and more specific questions. Questions like looking at patient demographics across years, being able to know the patient age of who is receiving those primary care services, what other types of medical conditions they may have, being able to identify specifically their zip code and to be able to do geographic and more demographic analysis. And so we presented this really as an opportunity as we think about how we might want to measure primary care spending, obviously on a statewide basis, but the value and perhaps also complementing that by looking at, specific populations, specific geographies, specific types of services, and how that might inform policy. I think Mike Caljo at the meeting, had a comment, I think urging us to think about ensuring that the primary care spending benefits that we hope to achieve, through the work of this task force truly do reach all corners of the Commonwealth and all residents of the Commonwealth, and how can we use data to ensure that accountability. So on the next slide, just some key themes and takeaways from that first meeting. Which is that, overall, I think there was an understanding that the way that CHIA has defined and measures primary care is a strong foundation for us to be working off of. And that really the potential next steps were around how do we identify the use cases for this data, apply the CHIA's primary care definitions, and that it may be appropriate for us to think about a methodology for the purposes of setting an improvement target that might be slightly different than just for the purposes of overall transparency, which is really its purpose today. I think there was additional discussion about the inclusion of certain types of categories of services in thinking about the total percentage of spending that goes into primary care. And then there was also, I think, a good discussion around how do we incorporate, or how does the data incorporate behavioral healthcare services that may be provided in a primary care setting, and how do we want to incorporate that, as well as thinking about kind of the whole, if we're moving towards team-based care, again, how are we going to be able to capture that and ensure that if we are setting a spending target, that we're going to be able to kind of capture all of the different elements of team-based primary care. And so
David,
I think
there's
some
some
more.
questions.
There's
There's
two
questions.
Yeah,
Doctors Friedberg and Krishlon.
thanks, Mike. I was just going to put a bow right on the slide and then turn to questions. But in any case, I just to finish the thought, I think some more discussion and definitely work to be done as this data and research work group continues. But would love to turn it over to Mark Friedberg. He was a member of the data and research work group, so please feel free to add your questions and comments to the discussion.
Yeah, thank you, David. I wanted to make two points. First, I believe we're still unclear on whether the CHIA and HPC definitions account for Medicaid provider taxes and their incidence across different parts of the provider ecosystem. Without including those, we could have a misreading of MassHealth's percentage spend on primary care, which actually could be higher than that reported by CHIA, depending on how those taxes fall. But it also could be lower. We just don't know, because that's an important thing to account for that is unique to MassHealth. The second thing is we had discussed, I believe, in that work group, when we think about however defined, stratifying the targets for primary care spending by patient characteristics, not just provider characteristics. So critically stratifying by granular age category, because we could end up in a situation where folks without spending any more on primary care end up looking like they've hit a target because they happen to have a younger population. And similar stratification will probably be necessary for patients with different chronic conditions.
Thank you, Mark, and agree with your points there. And as I said, some continued questions that we need to track down as we're continuing this work. Renee, please.
Hello, I commend the work of the work group on the data. I do think what I'm seeing as a missing point is primary care is such a low margin industry. We basically, the operational margins from independent practice are anywhere between 2 to 4%, and many operating margins are negative for doing primary care clinics. And large health systems talk about losing $100,000 per primary care doctor in their operating margin. So what I'm concerned about is if we just approach this from the revenue side, we're not going to fully be able to have as powerful impact as we can. One of the things that I think we need to be considering is if operation marginals are that slim, what are the kind of impacts that things like billing? My organization alone, we spend about 5% of our revenue generated goes directly towards a billing company, 5%, and our operation margin is less than that. And we can't be the only one. So when I'm looking at data that might be very helpful is if we can approach this from both the revenue side and also if we can simplify so that we can decrease the operational expenses, we can have a force multiplier effect. I mean, if you just think about the fact if you have a 2% operating margin and you decrease your expenses by 2%, your operational margin goes up to like 5%. And that's without adding any revenue. So what I'm asking for is it possible that we can also address what kind of impact things like simplifying the billing process or simplifying some costs so that we can approach this and leverage both the revenue increase and the operational expense decrease by simplification? Because that is a force multiplier. That will double our investment in primary care right there if we can somehow create a pattern that decreases the expenses on the organization.
Thank you. Thank you for those comments. And I absolutely agree. And I think that is really the overall charge of this task force. I don't think a spending target alone does everything that we need to be doing here. It's a spending target married with changes to the actual practice of medicine that make it more simplified, that take a needed expense out, that we pay differently to support primary care teams. So I think all of these, kind of levers kind of have to fit together. And I'm excited. I think Chris Kohler can really be able to speak to that. But it's a really great point. Thank you. Judith Malin?
Yes, thank you. A great summary of our initial discussion. I'd like to add a comment to the first point, which is for us to be aware that the great work by Chia and others has not heretofore been able to include traditional Medicare information. And we should just be mindful of that. In my ideal world, I'd love to see that be able to be added in. That ideal world may not be available, but at least taking into account the fact that considerable care is delivered to traditional Medicare beneficiaries by those that we're categorizing in the primary care bucket, if you will. We should be mindful of that. Thank you.
Thank you. Thank you for adding that clarification. And that was something that came up in our discussions. And I think something we're still exploring about, are there, other avenues that we can get some insight and view into that? Because as you said, it's a big part of the story here. So I really appreciate you mentioning that. Senator Friedman?
Yeah, thank you, David. This is really interesting. I have, well, three points. One to follow on to Renee. If we're going to calculate, the losses in primary care, we also have to add in the fact that they are enormous. They are the feeders to the hospital system. So to just say how much, they're costing the system is disingenuous, given that they're actually, they're the salespeople, they're the front door, so if they go away, lots of things happen in that healthcare, in that system, that system is not going to benefit from. The second thing is, and I think we need to start putting that in because that counts. The second thing is that in the last bucket, I don't believe that the definition belongs in statute, but what does belong in statute, I believe, is a framework to define the definition.
Mm-hmm.
Like we need to something needs to be pointed to that's fairly consistent. Otherwise, every time the regulators change, the definition can change, or there can be, or you can get into situations where somebody doesn't believe in something and then it becomes a political issue. So I think we just have to make sure that we're pointing, or the language is saying there has to be some independent verification of this or independent place to go to find that definition. And then I would just be a little bit mindful of not making this too complicated, because if you get into a situation where you're saying you have to look at this and you have to look at this and you have to do that, and this is it's the way we get in the way of ourselves. So the good should not, the perfect should not get in the way of the good. And as long as we're tracking fairly you know, that we have something that we're saying this is a pretty robust definition. I mean, the all pair claims doesn't have everything in it, right? So, you know, we're all kind of already at a bit of you know, not a loss, but you know, we have a bit of a challenge. So I would just argue against getting too perfect or too complicated. Thanks.
Thank you, Senator. Your guidance is very welcome on the balance that we need to strike with our deliverables here in the specificity, but still allowing for future flexibility, and what does a framework and a process look like, and how can we stand behind that? So I appreciate that. Dr. Spivak?
I did, thank you, David. I did put it in the chat, but I really need to just emphasize that so much of what primary care is all about is not done in claims. And, you know, we all know that as primary care doctors, we spend an incredible amount of time doing administrative work ourselves, but the amount of work that is done and should be done by a pharmacist, nurse case managers, social workers, to help patients get what they need to have good care. Nutritionists are not always included in these kinds of analysis. And if we're really going to look at the investment, actually, in many ways, that's where the added investment needs to go. So how we manage to look at what we're investing, and we don't want to create an environment where people now have to hire more people to document what others are doing so we can get the right numbers. So it's a matter of figuring out how to do this in a very simplistic way, but really gets the right information to us so we know, are we really increased spending, and are we getting the outcomes that we think we are because we're doing that? Thank you.
Thank you. And I'm excited to hear what Chris Kohler what has to say about those comments, because I think there is the one thing of, do we want to spend more? Where do we want to spend that more? In what areas, and how do we track that? And is it not maybe in what we've been tracking so far? So I think a good conversation to come on that. Dr. Dixon.
I just wanted the importance of Senator Friedman's point about the downstream referrals and understanding the overall impact that primary care has on a healthcare system is at the crux of this whole thing. When I started 13 years ago as CEO of this healthcare system, we did those calculations. We do them every year. And despite the direct loss on a primary care practice, the downstream referrals for labs, x-rays, imaging, surgical referrals, specialty referrals, pharmacy increasingly made up for that loss. And it was about a plus $125,000 per primary care practice. And I've watched over the 13 years that deteriorate into a negative number. So the old school sense, and it was true, very true, even in my career as a CEO, that primary care makes up for the direct loss through the downstream referrals. That downstream margin has deteriorated so much that now if I look at family medicine, and I have a former and a current family medicine provider for us, and on the committee today, family medicine, the net overall, everything in is a minus $50,000 a year. So every family medicine doc I hire, despite the downstream, we're going to lose $50,000. So, and that's part of why you're seeing the 6 largest healthcare systems in the state have an average operating margin of minus 2% over the last 5 years. And that's CHIA data. That's not my data. And it just, the overall impact of primary care on a healthcare system has gone from positive to negative in the last decade. And that's why you see less and less investment in primary care over time from the primary employers of primary care docs in the state, those 6 largest healthcare systems.
Thank you. Dr. Pring?
Just wanted to comment also in the work of primary care that actually keeps patients in the medical home and not in the hospitals, as the telephone calls They're done often by our excellent nurses, the portal messages that are managed by staff, but also by the primary care providers. And that, can be a potential savings, but really does not reflect it in the claims data as that extra work. Except I did see a comment about, yes, depending on the ACO models, that is something we should be considering.
Thank you. Dr. Martin?
Yes, and thanks so much. I'm very grateful for this discussion and grateful to follow Dr. Dixon and reflect on being a primary care doctor. I think we have to be absolutely explicit that the pricing mechanisms for healthcare are arbitrary. The cost I generate and the revenue I incur as a primary care doctor are arbitrary and established by not me, not patients, but a market that has full of entrenched interests that love, generally historically, the RUC and the AMA have loved proceduralists and loved medical center-based operations, including procedures. These are not tablets given by Moses. These are pricing mechanisms that Massachusetts can retake and reclaim from historical inaccuracies. Four of the CMS administrators have said giving the pricing mechanism to the AMA was the biggest mistake the United States ever made in healthcare policy. And we're suffering that, as Dr. Dixon described. I'd also say it would be actually a good outcome if I was referring less in my own system from primary care because I was giving a knee injection that made it so that someone didn't need an orthopedic referral, or I was treating addiction or mental health in ways that people didn't need other behavioral health referrals, or I was doing complex care and illness like COPD and otherwise so that other specialists weren't needed. And when the specialists are needed, sadly, throughout the Commonwealth, we're looking at 6 to 12-month waits for specialist visits. And that means as a primary care doctor, I'm now not only trying to figure out someone's emergent medical need that I would not have referred them if I could have figured it out. And so I'm developing my own skill set, which is fine, but I'm also handling patients' worry and concern that they're not being able to get the care that they need and looking for me to intercede. So thank you for letting me build on this idea of like how we cost things is arbitrary and not from a true market. It's distorted. So thank you.
Thank you, Dr. Martin. And just to add my own personal commentary, I can't help myself. I think when markets fail, and I think we have seen a market failure in primary care, then there is a role for policy change. And I think that is part of what this task force is charged with helping develop. All right, I do want to be able to move on to the next work group. So I see Barbara Rapson and Executive Director Peters, and we'll stop on the data and research for today. But go ahead, Barbara.
Okay, thank you. So I'm just following up on the prior two comments about payment and how it works and incentivized. And I think, after spending a lot of time really thinking about this and being so frustrated why healthcare systems don't care that primary care is in decline and in crisis. And it's because it's because all the incentives are in the opposite direction. Like there's no incentives to care about primary care. Our system is built to reward people who take care of sick care, who provide procedures and preventive care and managing chronic disease and spending time with patients and building relationships. The system doesn't reward that. And I think that there was a promise that global payment would do it. If we just move away from fee for service, why, how long have we been saying that? It's been at least 10 years and look where we are. So I don't know. I think we'll do a better job if we acknowledge that it's not there's, bad people, that are running hospitals, or it's more that look at the incentives that are in place to make people do what they do. And how do we as a group say, okay, let's acknowledge those incentives and it's all pushing against us. And what is it that we need to do to create a path forward? Because what we really need to do is use look at the public health of our communities should be our North Star. And I think we've lost that. And so the question is, how do we in Massachusetts get that back?
Thank you. Lauren, I'll give you the last word on this agenda topic.
Sure. And I really just wanted to clarify, particularly for members of the public that can't see the chat right now, but in response to some of the comments around how do we capture those services provided not through or not captured in the claims. And to sort of go back to data sources, we take a dual approach, as referenced earlier. We do look at APCD claims, but really CHIA's primary source of primary care spending data is through payer aggregate submitted data to CHIA. One of the categories in that is non-claims payments paid by health plans to providers. And while I would note that it's not a perfect sort of definition, and it may not capture every bit of spending, nor does it capture sort of exactly where those dollars go to within that provider system. I think this is an area that we're spending a lot of time really trying to refine and get more granular in our definition of non-claims payments to providers, and working with other states, because I think this is a big topic amongst other states that are trying to advance primary care and capture this spending data. But with that said, would welcome any feedback or suggestions as we are trying to sort of land our data specifications by the end of this month for reporting next year.
Thank you, Lauren. And one of the other additional topics that this work group will be thinking about is there a need for additional reporting to understand the flow of perhaps non-claims payments to a health system to ensure that are those actually going to support primary care within that system. So another complex topic for us that we'll be tackling at our next work group meeting. So thank you so much for all the commentary and questions. Actually incredible. And I'll turn it over to Kiame to talk through our workforce work group. Thank you.
Yes, thank you. And Lauren Peter said something that reminds me. The public, the members of the public cannot see the chat. So if you're making a comment that is meant to clarify things for the larger public, they're not seeing the chat. And we'll probably figure out a way to print the chat out so it's included in the minutes, but nevertheless, it's not real time. So just remember, if you have a point you make that you think is particularly salient and important for the larger group to see, you're going to have to raise your hand and say it out loud. So our workforce work group, David and I both agreed that it's a tongue twister. Our workforce work group meeting occurred on June 12th. And the Health Policy Commission presented research from the report on primary care released earlier this year to provide background on current primary care workforce trends and challenges in the Commonwealth. So the key discussion themes are listed there. So I'll just read the titles and I won't read everything under them to give us more time to discuss. So increasing the primary care workforce pipeline, investing in team-based care, and regulatory and policy options to reduce provider burnout, particularly around administrative requirements. So I will offer an opportunity for different members of the work group to comment on specific points that were made during our meeting. So I'll open it up. Please go ahead, David.
Great, thanks. So I wasn't able to really get all my points across around this topic last meeting because of my audio, but it seems like a small thing, but it hopefully will be a relatively simple thing around the payer credentialing. So I think there could be workarounds like shortening timelines and allowing for clinicians to be able to streamline credentialing. But one thought I had was if we were to require that payers in the state all provided retroactive pay, we could get patients access because we have clinicians who literally have joined systems who don't have full schedules because they don't want to see patients that they know they can't get paid for because they're not credentialed with yet. And so that's limited access for patients. It's limiting clinicians being able to see patients. And while I realize this is just a small piece of the access issue, very small, it seems like a relatively simpler thing to solve for. And so again, if there is a way to actually legislate or move that we can have retroactive payment, and I know a couple other states, I believe, have done this.
Thank you, David. Christina.
Thank you. I'll just build off of that since I think that I was the one who brought up health plan credentialing. And I think I was a little bit more specific in what I said, not that that needs to be captured on this slide for today, to share with this group what my recommendation was on health plan credentialing. It was to have the Commonwealth of Massachusetts create a centralized entity, an existing entity or a new entity that has accountability and authority for unified credentialing, and that if a provider was credentialed by the authority in the Commonwealth, that they would be de facto credentialed with everyone licensed to do commercial business in the Commonwealth.
Thank you. Thank you for that, Christina. I was going to take a co-chair prerogative and ask Laura Pellegrini, the idea of having like a centralized unified credentialing process, does that represent a problem for health plans, or would that be seen as a boon and a decrease in costs?
Thank you. You were channeling me, so we're on the same wavelength. So currently we do have a process in place. It's probably been in place for 15 years, known as HCAS, and that is a central credentialing activity, and that is something that the health plan set up at the time many years ago. Again, Mass Hospital Association worked with MAP on this, and that is a place where we do have unified credentialing form. Everything's been automated for years. And I think about it in a lot of ways like what you do for a college application, where it's a universal application, and then the plans can pull down that application. HCAS does all the primary and secondary verification that needs to be done as part of NCQA accreditation. And then the plans can pull down that information to do their credentialing. So it does exist. We can explore that a bit more, Christina, to see if that meets the needs that you're thinking about. But I think the plans do individually need to still credential based on NCQA requirements. But we should take a closer look at that, David, for the group. So Kiami, I don't know if that helps you.
It helps a little bit, so thank you. We'll definitely pursue that discussion because we had talked about the NCQA process and whether we could tweak it in some way.
And could I just make another suggestion? So on the slide, on the third bullet, it says remove prior authorization requirements. I'm wondering if a better phrase would be to reduce prior authorization requirements. I don't think we want to leave anybody with the impression that we want to fully remove them unless that was the intent. I think the idea would be to reduce.
Thank you, Laura. We'll go to Renee.
Thank you, Kiami. I do think that part of what is not captured from this slide is the impact of burnout. The fact is we have a large amount of primary care clinicians in this state. And I think it needs to be reaffirmed consistently that the lack of patient access is due to the administrative burden that is pushing people towards more part-time, quote, careers in primary care. But the fact is we have a significant number of primary care clinicians right now. And if we remove that burden associated with administrative, then honestly, we don't have to graduate another person from medical school right now. We could improve our patient access by 20% by pulling teams together and allowing people, and that's immediately without adding anybody. So I do think it's important that we get both sides of the pipeline, the folks that are in the pipeline, but the folks that are out of the pipeline. And out of the pipeline and facing that burnout is making it so that less than 20% of primary care physicians are practicing full-time patient-facing. And I think that that's critical. It's not a backdoor discussion theme. It's an important part of it.
Thank you, Renee. And we're aiming for around 11 a.m. starting our discussion with Chris Kohler. So we'll go through Barbara, Stephen, Laura, and Michael, and then we'll see where we are in terms of time. Go ahead, Barbara.
So I actually agree with the comment about instead of using the word removing prior auth requirements, lessening prior auth requirements. But I also, when I think about reporting requirements, I think about the challenge that we all have around diagnosis coding and the amount of time that it takes for me, particularly as a primary care doctor who has a wide breadth of diseases and issues that I deal with, making sure that I've properly coded for the patient, and the expense that my employer and all employers use to make sure that everyone is properly coded, which is important because the sicker your patients are, you want to get paid appropriately. But I also went through and thought about all the work that I did yesterday in signing forms monthly, in having to do prescriptions for people that I've taken care of for literally 30 or 40 years and have never abused it, but every month I have to give them controlled prescriptions, and the amount of time it takes. So I think it's not about burnout. It's just about reducing the administrative time that we spend so that we have more time to actually be with patients. So my comment is that we should talk about reducing provider burnout and administrative time, but also look at some of the things that we have to do, like my patient has a total knee surgery, and I'm the one who has to every month sign for the visiting nurse and physical therapy. I didn't do the surgery, but I'm the one doing all the paperwork and reviewing it. There are many things that if you put us together in the room, we could come up with ways of lowering that administrative time that does not add value. Thank you.
Thank you. Stephen?
Thank you so much. Just appreciate a quick comment here. Just I do want to reinforce that my work at UMass is aided and abetted by a culture among the clinicians that is incredibly collegial. And this makes a big difference in terms of burnout because I'm able to work with colleagues in the ER and orthopedics and rheumatology and endocrinology, and they help patients all throughout the patient's span, even if they haven't seen the patient in person. This is an incredible asset, and I really appreciate the culture at UMass that allows this. I do think we need to be more specific about what the work of primary care is if we're going to talk about workforce. And there are a lot of things that happen in my clinic every day and in my service every day that don't require a health professional degree. And we really need to be clarifying what is the work that we're asked to do, and can we reallocate, or can that work happen elsewhere? And lastly, the first bullet, I'd be very cautious about the evidence on student loan forgiveness is very weak in terms of it actually being helpful. I was fortunate to be a National Health Service Corps scholar, and so much more effective model when people are allowed to choose primary care from the start and not face tuition and then try to repay it with their loans. So thank you.
Thank you. Laura?
Just quickly going back and pointing on the removing prior authorizations, I appreciate that, lessening them. I had mentioned in the meeting about encouraging some stability, particularly with PBMs, and looking at medications, not requiring patients and providers to have to bounce back and forth between one day needing to get a prior auth for a brand name drug and the next day needing to get a prior auth for a generic. So I really want to encourage that we consider providing some stability over time around that. In addition, the act of, I'm coming from the perspective of an independent practice, but the shifting tides of contracts and where particular insurances and health plans are accepted by specialty care. We're in a position, we're actually one of the few that take WellSense in the Worcester County and have a very difficult time finding specialty care for our patients, and that requires an inordinate amount of time on the part of our administrative team to secure needed appointments for our patients.
Thank you, Laura. And yes, in response to a question in the chat, John Hurst, there was discussion on that, and there are people who feel that that could be a potential path that could be taken in terms of encouraging people to choose a direct primary care model and therefore perhaps getting more people to go into primary care. That was an active discussion. Michael?
I just want to reflect back on the theme that we've been talking about here, which I completely agree with about the reduction of administrative burden as a key factor for the practitioners in primary care who are already practicing, as well as lessening the burden for those that are in the pipeline to come. I do think, however, we have to be really honest, and this group needs to do the homework necessary to understand how much of that burden is created and spurred on and accelerated by system burden as well, and not just health plan burden. I think the health insurance companies have acknowledged, and Laura did today, that they're, I think, interested and understand their willingness to do their own part. I know the Division of Insurance is tackling primary care, rather prior authorization reform as a first step over the course of this summer and fall, which will certainly include primary care in its scope. But there's a bigger opportunity here that we have to acknowledge and at least understand more. And I don't have access to this information, but the burden that a primary care practitioner experiences within a healthcare system has to be delved into and examined so that we lessen not just prior authorization burdens or pharmaceutical formulary burdens, but those burdens that are created and pushed down to the primary care practitioner from the large healthcare system. And I just want to acknowledge that and make sure that we do that work.
Thank you. And Wayne, you get the last comment.
Thank you. I'm struck by this group. The vast majority of comments, we're all sitting here going, yeah, we agree with that. And we're a group of really intelligent people, really busy people, and people who get the crisis of primary care and have big ideas about what needs to be done. And my comment is about process, because we had 2 fantastic working group meetings, and we've spent the last hour kind of reiterating the working group meetings. And since half of us were at each meeting, everyone felt the need to restate their comments that they made in the working group meetings so that the rest of the group could hear their excellent points. And I'll restate the point I made in our original task force meeting, which is we need smaller groups of 4 or 5 people to roll up their sleeves and get stuff done and make proposals. For example, we talked about credentialing today. 3 or 4 or 5 people could get together, learn about the credentialing situations, and propose something. The same is true for primary care spend. Same is true for prior auths. We could come up with 5 other examples of this. And so what I think we need to do process-wise is stop pontificating and making points that we all sort of know and all sort of agree with, and instead get to work, roll up our sleeves, make suggestions, and bring tangible suggestions back to the working group to then deliberate on. The last thing I'll say is there are 3 primary care bills that have been worked on for the last 6.5 years that are a long list of those ideas already existing based on these conversations. And a good start may be to actually go over the content of those 3 bills.
Thank you, Wayne. David and I will definitely take it under consideration as we sort of think about how to move forward and how to use the expertise and the time of the task force members in the most expeditious way possible. So I'll turn it over to David to present Chris and have Chris give our presentation to us.
Wonderful. Thank you. It is now my honor to introduce Chris Kohler, president of the Milbank Memorial Fund, to give a presentation on increasing primary care spending rates in Massachusetts and lessons from other states. We've been talking today, especially in the data and research work group, recap around the concepts of primary care spending targets. This is not a new concept to Massachusetts. This is something that, as Dr. Altman just mentioned, is a part of many of the proposals that are currently before the legislature. It has been proposed in legislation in the past here in Massachusetts. So while not a new concept, it is something that the legislature, through this statute, very explicitly asked this task force to make a recommendation on. And so I'm really excited to turn it over to Chris to talk about the principles of a primary care spending target, what we've learned as more and more states have used this as a lever to improve primary care, and how we might think about it in the Massachusetts context. And so very happy to turn this over to you, Chris. And please, members of the task force, encourage you to ask questions along the way, as I'm sure I'll want to as well.
Thanks a lot, David. David and Kiame, if you could sort of help me, I've got a view of the panel, but if you could help me identify speakers as they come up, and would to repeat David's invitation, would encourage folks to raise questions as we go along. Next slide, please. So this is what I'm going to talk about. I guess I will frame it right here to follow up on Wayne's comments, that my understanding, and I would advocate for this, is that among the myriad issues that are being discussed, there is at least the option or the possibility of prioritizing primary care spending rates as an area for interest, measuring and increasing them. And I'm going to try to make the case that that is an important thing to prioritize. And then, as David said, to learn from some other states. Next slide, please. So this is who Milbank is. Hopefully, most of you are familiar, have interacted with us in one way or another. We're an endowed operating foundation. We've been around for about a century. We do our work in these three major buckets of health policy leadership, working with state health policy decision makers such as yourself on specific issues, including primary care, and then publishing. I do want to take a pause at this point to thank David and Kiame for their leadership of this group. They encouraged me to come on at 10, and it's been a great education. I also have more respect for the work that David and Kiame have to do to wrangle all the engaged participants. I want to salute all of you for making the time to participate in this about something that you care about. But I do want to call out particularly Representative Long and Senator Friedman, who sort of commissioned this group, are taking the time to participate. And as we've learned this weekend in Minnesota, this sort of public service is an extra duty that people require, or that it places particular demands on them that frankly it shouldn't. So Milbank has had the privilege of working with a lot of legislators, elected officials. While we appreciate all public service, I think there are particular demands on elected officials, and just want to appreciate Cindy and John for the service that they provide and the work with this stuff. So thank you. Next slide, please. So this is what we're shooting for. I had the privilege of serving on the National Academies of Science, Engineering, Medicine panel on primary care. And this is our aspiration. I'm sure we're probably all in violent agreement that this is what we're pointing for. Primary care that consists of interprofessional teams that are accountable for addressing the majority of what's going on across settings. So we're not just talking about visits, and through sustained relationships. And it's easy, relatively easy to talk about in concept, but how do we get there? But I think it's important to sort of state the goal that we're all shooting for when we say primary care. Next slide, please. And this is the value, at least as Milbank states it. And again, I think we can put various degrees of emphasis or color on this, but we just want to remind ourselves the reason that we're talking about this is it is the only part of the delivery system where the more we have, the better our population health outcomes are, and the fewer health disparities we have. This is the value of primary care. You cannot say that about pharma or hospitals, and this is why we are focusing on trying to make sure we have a strong primary care base in Massachusetts and in the country. Next slide, please. So I want to make the case particularly for focusing on primary care spending rates. And you can call it different definitions. We've taken to call it primary care spending rates as opposed to primary care investment. Investment creates an expectation that we're going to generate a return within a defined period of time. I think that's a little bit dangerous in terms of the expectations that it creates up. And rates gets it to the idea that we're talking about proportion as opposed to overall amounts. First, there's considerable evidence that relatively higher portions of healthcare spending going to primary care are correlated with better health system. However you define health system, a country, a delivery system, a plan, performance, and call out Mark Friedberg. He helped us a lot with this work in a prior position they had around sort of documenting how to go about measuring it. And we've got lots of examples of that, international comparisons, performances of integrated delivery systems, performances of Medicare ACOs. And it's worth noting, as you folks all know, the scorecard that was just the updated version that Mass Health Quality Partners and CHIA put out, that Massachusetts is heading in the wrong direction. But the second piece I want to talk about is the importance, if we're all a bunch of insiders, I think the notion of focusing on primary care spending rate is pretty catalyzing for the other 80% of our of our economy, the people that are not healthcare, because they recognize the value of primary care. And routinely, when you go to them and ask the portion of healthcare dollars that are going to primary care, they estimate as something much higher. I had this experience in Rhode Island. The recent was work done by Kevin Grumbach that was released in the Annals of Family Medicine, where they went out and asked folks, what portion of the dollars in healthcare go to primary care? And they got estimates over 50% on average. And so I would encourage all of us who care about primary care, and I include everybody here, to focus on the importance of the primary care spend measure as a way of organizing, informing, and catalyzing public opinion, which is going to be really necessary because it's public policy that got us in this mess, and it's going to be public policy that changes it. And that means getting the public on our side for some of the changes that are needed. So that's my case for why, among all the things that we talked about this morning, you want to lead with primary care spending, because it becomes a way to make all the other work around workforce, around administrative burden, pipeline, that much easier to generate public support for. Next slide, please. So as an overview, now part of what David and Kami asked me to do is to help the Massachusetts group think about how other states have done this work. And I want to bucket the other state work in terms of these three general policy strategies. There are states that are aspirational, that are setting a target for one or more payer groups, and that's the largest, frankly, because that's the easiest lift. You get a bill that passed that says, we hope we can do this. This is what we ought to be doing. The second is something that's more directive, that matches those aspirations with some particular direction to particular entities. And the third is where states use their budgetary levers to actually institute specific payments and models. And I'm going to talk about each of these with some examples going forward, please. Next slide. So regardless of what you do, and I'm going to end by going back to this, particularly with some thoughts about Massachusetts, I think if you made the case that we're going to prioritize primary care spending rate, you have some design questions. Is it a target or requirement? How do you define primary care and eligible payments? How directive are you? Are we talking about any kind of primary care or, quote, good primary care? And that's we've seen or talked about that in terms of the work group that you have organized. Our denominator, what is the healthcare spending that we're talking about? How do we set a target level? Who's the entity that we're holding accountable to it, whether it's as an aspiration or requirement? How do we do monitoring and measurement over time and also have accountability so that we stay focused on this? And then this last piece is what I call breadth and depth, which is that one, do we have breadth? Are we getting enough money involved in our dreadedly complex multi-payer system? And then the depth is my way of categorizing the issue of are monies that are going to primary care actually benefiting the primary care team? And this is particularly important as more and more physicians and clinicians, excuse me, become employed in systems. So we can document that we're paying the system. How do we know that the money is making it through to wherever you want it to go? The clinician, individual clinicians, the clinician teams, whatever we define as the primary care entity that we're measuring. So I think these are design questions. I'm going to talk about what's going on in other states and then return to some ideas for what Massachusetts might do. Next slide, please. So an aspirational example is California, and I'm going to pick them because they're most recent and they're big, and maybe, you know, we can get a little bit of state competition between Massachusetts and California. A statute established a healthcare affordability board. And that job in statute of the board was to set targets for commercial health plans. They adopted a definition, the work that you guys are doing, how to measure it, and they reviewed historical spending levels using that definition. It was about 7% or probably a little bit less. And then they just set out a target to increase commercial health plan targets to increase by 0.5 to 1 percentage points a year with a goal of reaching 15% by 2034. This is my editorial comment. It's what I've seen looking at 20 states that have done this. Aspirational targets do not work. None of them have resulted in an increase in primary care spending as a result, or even a move to more aggressive policy requirements. And I think there are lessons for us. David and I are veterans, as well as other folks, number of folks from HPC, around healthcare cost growth targets. And this is the question that those states that are involved in those experiments are asking, is that the targets are might be conceived as necessary but not sufficient. And I think if we talk about targets, we have to consider that. Dr. Critchlow, I see you have a question or comment?
Yes, Chris. First off, thank you for coming and speaking. Your information is always appreciated. I have a question on the commercial health plan targets. What was their ability to enforce that? How did they get around? So they had no ability to enforce this. They had no plan to get around ERISA. What was the path forward
Right.
that they
No. First of all, these are binding to commercial plans, not to self-insured products. So you've written off large employers completely. And what I meant to convey by saying aspirational, these are merely targets. There's no enforcement mechanism at all. We're going to talk about examples of enforcement mechanisms in the next example.
Okay, thank you.
Yep. Next slide, please. So a couple requirements examples. First of all, Rhode Island, which is one that I'm familiar with as I was health insurance commissioner in Rhode Island when we started this work. About 2010, we made a requirement of commercial plans as part of what we called our affordability standards as a condition of getting rates approved. So we, in Rhode Island, have comprehensive rate review authority over individual, small group, and large group. And with the help of an advisory council that was focused on all commercial insurance, they were advising the Office of the Health Insurance Commissioner on all aspects of health insurance oversight, not just primary care. With their input, after reviewing a number of things that health plans could do to improve affordability, we landed in part on this primary care piece. We focused on some other things as well, which are not germane to our conversation on primary care. And it was actually a condition of rate review. It eventually moved into regulation that health plans had to increase the portion of dollars going to primary care by a point a year over 5 years. It was explicitly redistributive, meaning that health plans could not increase their overall spend to meet this goal, but they had to find the money other places. We had a pretty crude definition of primary care, simply defined by specialty. We had a pretty broad definition of what was allowable, including a lot of non-claims-based payments. It was, to Renee's point, fully insured only. We did not get any kind of breadth, no relationship to Medicaid, Medicare, self-insured. It relied on plan self-reporting. Eventually, it was moved from a condition of rate review into regulation in 2013. And rather than a point a year, they just wrote a target into regulation, a requirement of 10.5%, which has been consistently met by plans. It's worth noting, and your definitions group, if they haven't, may want to get into this, that the regs were rewritten just this year with a tighter definition of primary care, a narrowing of allowed expenses, and an expanded denominator. And I'm actually not super familiar with the specific details of what they did, but you can talk to the folks in Rhode Island about it. The net effect is going to be to put more dollars in, but only for the commercially insured piece, which is only 35 to 40% in Rhode Island of the employer insurance market. It is a small piece of it. And to Renee's point, we have this issue around ERISA. So we've got to get, well, I'll talk about some strategies for approaching that. Next slide, please. The next example is Oregon, which followed our example in Rhode Island and went a little bit more aggressively. They set spending levels in statute for Medicaid managed care, Medicare managed care. I'm not quite sure how they did that, commercial and public employees plans. And they said all were required to reach 12% by 2023. As near as I can tell, there are not different targets by payer level, which is pretty crude to the point that Mark made earlier in our discussion. And it was an expansive definition of primary care. I think that is most important as you think about your work. The monitoring is by the Oregon Health Authority, which is the entity that regulates Medicaid and also does public employees purchasing. And it was paired with a primary care transformation center in the Oregon Health Authority that was funded in part within a Medicaid 1115 waiver. So they really did a nice job of trying to link some of their efforts across payers, address that breadth problem that I was talking about. But it's not clear it remains unclear what their enforcement mechanism is for entities that don't reach the target. I've got another slide on this, I believe, if you go. Yeah, where they are as of 2025 is in aggregate, everybody's meeting some of the standards, or the system is. You see the performance by different Medicare Advantage carriers. Oregon Health Authority does an annual report on this, much like some of the HPC and CHIA reports that they do in areas of interest to policy areas of interest to them. But you see enormous variation in the performance of particular commercial carriers, Medicare Advantage carriers, and even public employee plans. And it's not clear to me that there are any consequences for this variation. So Oregon's doing a great job of measuring. It's not clear what the follow-up is. Next slide, please. So the last example that we have, remember, there's aspiration, there's specific requirements, are specific payments and models. And I think you actually have a fine example of that in the work of Mass Health. Some states have simply just said, you know what, within Medicaid, we're going to pay particular attention to our primary care fee schedules. And remember that the Affordable Care Act actually passed additional federal dollars out to state Medicaid agencies to increase Medicaid primary care rates to Medicare levels. That spending, or that supplemental federal dollars, went away, and most states just let their primary care rates fall back. Exceptions are in Connecticut and New Mexico, which have explicitly pegged Medicare, and there may be others. And then Oregon and Massachusetts have been leaders around not only paying primary care more, but paying them differently with the Mass Health program. It's worth noting that increased primary care spending rate in Medicaid, as I understand it, is a desired outcome, but it's not an explicit goal. So Mass Health was trying to achieve some other things, to pay primary care differently with a capitation rate, to have supplemental resources. But as is documented in the recent primary care scorecard, it is the only payer group where primary care spending has actually increased, and that's not by accident. That is a result of specific policy efforts by Mass Health. Next slide, please. So what are some lessons? We have partial victories at best. It's really important that primary care spending focus could be seen as, again, necessary but not sufficient. You don't have primary care clinicians in Rhode Island or Oregon that are rolling in Clover right now or have everything satisfied. There's talk of a primary care crisis there, just like other places. So don't think that primary care spend is going to solve everything. We did have a magic moment in Rhode Island. It's a little bit, we didn't realize it when we were in it, and it's worth thinking about how we got there and how it's gonna, the moment has passed and what we can do to recapture it. And the moment came when we had primary care driven groups that were forming ACOs. They were taking advantage of Medicare MSSP, forming ACOs. They were negotiating commercial contracts and Medicare Advantage contracts to match their MSSP. So they were aligning payers, and they were taking advantage of the primary care spend requirement to get infrastructure payments out of the health plans to support their work. This generated very high, or a couple high performing MSSP ACOs in the early teens that ranked very well in CMS evaluations. That passed over time. You had practice consolidation. Both of those, well, one of those ACOs was acquired by a health system. You had high cost drugs that were blowing up their, they were out of their control and blowing up their performance. You have Medicare Advantage losses. And as a result, both the infrastructure payments and even the ACO arrangements themselves have been threatened. So it's not clear how to recapture that, and if whether the new spending regulations can mitigate it in some ways. I also think in Rhode Island, we had some design flaws. We had no strategy for engaging Medicaid or public employees. If I had to do it over again, we would pay more attention to that. And we didn't see consolidation coming. And we've had a lot of conversation here about how to make sure primary care spending to health systems is making it to primary care clinicians. And then we had implementation flaws. We had limited monitoring. We were relying on plan self-reporting. And I think most importantly, there was no external entity, no task force such as you folks, who was holding government accountable for implementing these and keeping this as a focus. Yeah, Lauren, I see you have a question.
Sure, no, thank you for this presentation. Really helpful to get this in-depth view of Oregon and Rhode Island. So it looks like on both, for both Rhode Island and Oregon, the burden is really and onus is on the payers. But we know that, and sort of to a point that you made earlier, we know that so much of the dollars, once it is, whether it's handed off in rates or capitation payments, goes to the provider system. The provider system also has control over where these dollars go. And so did any of the other states, or in your work in this space, have you contemplated how do you set targets or track and hold provider organizations accountable in the same way that you're holding the payers accountable?
Great question, Lauren. I've got some speculation on that at the end. The short answer is, I think people are looking to Massachusetts to lead the way on that, just like you did with healthcare cost growth targets. People have not figured it out. There's a little bit of fear that well, no, I shouldn't say, because I have a fear that the only answer might be to oversight of health system finances the way that we oversee insurer finances. And I call that fear just in terms of the regulatory apparatus that's required to do that. Then in effect, we have to have a bunch of examiners for health systems the way we have examiners for banks or for insurance companies. But I think this is the new frontier. I would encourage us not to use that as a reason not to do it, but to acknowledge that we're going to be learning how to do that in more effective ways. But it clearly is something that we have to understand, and we should do it in partnership. And I will, with health systems, I will say this question would be, maybe not moot, but certainly less important if health systems were accepting financial risk, because then primary care could find its own level. You know, we don't, we didn't worry about this with primary care physician groups. I've heard Rishika Fernandopoulos talk about early IORA, and he was spending like 13-14% on primary care just as a strategy because he was taking risk for it. And so I think if we could, we wouldn't have to put in place this oversight apparatus if we had different financing arrangements with the health systems. I see Barbara and Eric. Apologies, I don't know all of you, but I'm using first names, so I'm getting very familiar.
Chris, thank you. This is Barbara Spivak. There are a couple of Barbaras on the call, but
Okay.
So thank you for this. And, I think one of the things that a number of us have talked about in some of our prior meetings is the fact that, and I think you heard this from Barbara Rapson earlier, that in Massachusetts, the majority of primary care is now employed by academic medical centers or for-profit organizations, and that their goals are very different than the goals of primary care in many ways. They are looking for expensive procedures that will get highly reimbursed, hospitals that have a high number or a high percentage of their patients are medical patients versus surgical don't do well. They want the high-end surgeries. So the incentives are not aligned when you're looking at primary care versus the current system. And most of healthcare in Massachusetts is in some form of risk arrangement in terms of the commercial plans, shared savings, and Medicaid. And it is not turned things around. So one of the ideas that people have thrown out is, should primary care be taken out of these big systems and run in a very separate way by and specifically for in a primary care organized group, so that an academic medical center and system is not controlling the dollars and the workflow, et cetera. And I'm curious what you think about that. I don't think we've seen it anywhere in this country. Certainly, if you look at some of the European countries, primary care is dealt with very differently, and their quality and expense is definitely lower. Wondering what your thoughts are about that.
Oh, Barbara, do you really want to wade into this pitch battle in Massachusetts? I've been talking to Wayne about this for a while. I'm aware of the different legislative proposals. I think so you're right. No other state is doing this. There are a few places where it's been considered. I'd say if you think about policy in general, you want to proceed incrementally. You want to build on the capacity you have to do this, which often ends up being the FQHCs. I think about a place like Vermont, where 1 in 3 residents get their care in an FQHC. And so you have, it's sort of an easy, not an easy, but a base from which you can build out. I do worry that if and an advantage, and we've talked about this, is that you could include self-insured funding in there because you would find a financing mechanism to get there. I really worry that we would do for primary care what we've done for public health, that we would not have in place the structures to keep the funding adequate over time, and that we would starve it. And so if we proceed in that direction, you've got to think not only in terms of the next year, but the next 20, in terms of how do you put in place a political structure to make sure that those resources are adequate over time. And I would think incrementally, you might, you start to do that. You'll hear me say this a number of times. Mass Health's capitation arrangement allows you to think about that. It starts to become a bridge. If you could get other payers to be paying in the way that Mass Health is, you'd still have to think about the self-insured piece, and then you'd have to think about what's the next step where the money is not flowing through the plans, but it's flowing directly from some sort of a collected entity. So Barbara, that's a little bit of a dodge in terms of specifically committed, but it's how to think about it going forward, because it clearly does address the self-insured. I think that's its biggest virtue, and maybe the employed physician. But we've got to protect it, because we don't want to do for primary care what we've done for public health, which is just kind of starve it over time. Yes, Eric, and then Ryan. I want to make sure we don't. I have some design. I would encourage folks, I do have a couple slides at the end where it tees up specific questions or ideas for Massachusetts. So some of the ideas might be covered then. Yes, Eric.
I like Barbara's idea of having a centralized primary care base for the entire state run by some other organization. And all of us getting out of it. And I just don't see it ever happening. And so I think to Executive Director Peters' comments, there's 6 healthcare systems in the state that control the vast majority of healthcare, and it occurs here. 2 of them control more than 50%, and they're not disproportionate share providers. The other 4 have almost twice as much Medicaid as those 2. And I'm not picking on anybody or saying some are bad and some are good, but the solution is going to be very different for the 4 safety net healthcare systems versus the 4 primarily commercial systems. And that has to be taken in consideration. And if you don't understand what's going to happen within the healthcare system with anything that you might do, then you're going to get you're not going to get the desired outcome. What's going to happen if you tell UMass Memorial, we're going to give you some extra money for primary care, but you can't spend it on reducing your loss on primary care? Well, I'm still in a loss on primary care and can't grow it, trying to make up for the losses somewhere else because you told me to spend the money on, I couldn't subsidize the loss. So you haven't changed our need to potentially reduce a primary care footprint because of the losses accrued. And that includes the downstream losses. So if you don't look at it from that lens at some point, what's going to happen when the money hits the big systems? Then you're going to end up like a lot of things with an experiment not generating the results that you were hoping for in the end. But great presentation. I'm looking forward to the final few slides because I think you make some great points there.
Well, thank you. Maybe before going to Ryan, I would say there might be, based on what she said, and again, I'm sorry, I hope it's not too familiar to work on a first name basis, but Eric, based on what you're saying, maybe there's a case for the question that Lauren asked around measurement. Can we at least measure where everybody is and at the delivery system level so that at least gives us a base of knowledge to proceed down any of these paths? So maybe part of this is it's inadequate or it's not all the way there, but we've got to continue to work on our measurement infrastructure. We've done it for plans, and the next frontier is doing it for these systems because we're not going to unconsolidate these systems. So we might want to have the public oversight mechanisms to understand what's going on within them. Yeah, Ryan?
Thanks, Chris, and thanks for joining us today. To go back to a couple of comments and Eric to actually hit on your and Lauren's measurement piece. Eric, as you are probably familiar, our ACO contract with your system actually does measure how sub-capitation dollars flow once they hit your system and ensure, or at least attempt to ensure that those dollars are going to primary care. I will offer a few caveats. We've seen a number of comments in the chat just about how Mass Health is doing this. I think a few caveats to what Mass Health has done. One, I think we are obviously biased. We think we have a decent foundation for a system moving forward. And without other payers and other systems at the table all doing this together, Mass Health is 5 to 25, maybe 30 to 40% of any single practice's payer mix, and we will not be successful in actually changing either the amount of investment in primary care and or the way it is functionally paid at the practice level. And so great, and we need everybody else around the virtual room to either be doing something in sync with us, or we need to collectively decide on a different model. To be clear, we are not anchored to our model. This was a V1.0. For those of you who have participated in the program, we've certainly gone through V2.0 and V3.0, and we are trying to rapidly iterate and learn. And would welcome this group's input on how we can continue to improve that model. But ultimately, a single payer trying to do this on their own is going to be a setup for failure. The second point, though, is to the point around measurement. We do have built into our ACO contracts reporting requirements for where primary care capitation dollars go once they are in the system. Again, it is a V1.0, and there is a lot of opportunity for improvement in terms of how we can measure that, what the visibility looks like, and ultimately what that means from the system perspective. So I would caveat it as we see it as an initial entree into trying to address, Lauren, kind of what you're discussing and holding systems actually also accountable as a part of this. It can't just be pairs. It has to be both of us holding hands and working together on this. And I think we also have a lot to learn in terms of how we think about measuring where dollars flow once they are in a system. It is inordinately complicated, as we are learning very quickly. And I'm sure we've gotten some things wrong. I'm sure we've gotten some things right. But I would also say that I think that the more this group and any future mechanisms we build as a Commonwealth can address that piece, I think doing that together is equally important as setting a target upfront, but also being able to measure where those dollars flow.
Chris, if you want to finish your 2 slides, since we're getting close to time, if you to finish your slides and then go back to Wayne and Mark, or so you can finish your presentation, that'd be great.
Thank you, Kim. I hope, Wayne and Mark, you okay if I just sort of zip through these and we can have the discussion? Okay. Next slide, please. This is just a slide about Medicare and what Medicare is up to. You guys made a run at it. Oh, sorry. I had a slide I pointed in here about making care primary. It didn't make it to this version. I guess most version control on my part. Medicare alignment is important. There are 2 opportunities. Most recently, one was making care primary, which you guys made a run at, and then there were I think some design issues, and so Medicare did not get a whole lot of practices to sign up for it. So it should be no surprise when they discontinued the new administration discontinued that project. The other opportunity is ahead, which is a very comprehensive, complex effort to do global payments. There is a primary care portion in it, and it focuses on increased investments and alignment across Medicaid, Medicare, and commercial payers. Rhode Island, Vermont, Maryland, and Connecticut are trying to make ahead work. The jury is still out on that. My observation is that states do better with Medicare when they know where they are going and get Medicare to align with them, as opposed to look for the signals from Medicare. And I think, frankly, you guys have, because of the work with Mass Health and these sorts of discussions, you're in a position to negotiate with Medicare if and when they pay attention. And I think they will go back to primary care. It may be more focused around small practices and rural health, so it might not be a fit for Massachusetts. But ideally, you want to be aligned with Medicare as well. And I will put as an interim step, and the folks may want to think about this. This is not part of primary care spend, but as an implementation, I continue to bring up the advanced primary care management codes within Medicare fee for service. And until you get to the point of larger alignment, at least looking at uptake of the APCM codes in Massachusetts at least gets people on the road towards capitated payments, paneled patients, increased primary care spend, all of which is important. Next slide, please. So these are 2 slides I got 3 more slides, 2 on the design questions for Massachusetts and 1 that's sort of a wrap up. If you think about the questions that I put out there, my own opinion is that targets are not really all that effective. If you're going to look at setting primary care spend and focusing on it, you want to not only measure it, but you want to have some requirements, and you want to think about enforcements. Your numerator, you've done a lot of good work. We had a spirited discussion around it this morning. I do think that Rhode Island represents the best of breed nationally. The California definition adopts what Rhode Island has done, so we can learn from them. The denominator, you folks are you've got best of breed because of all the work that you've done with measuring primary care spend, cost growth targets with CHIA and Health Policy Commission. So you're in very good shape there. I would not get wrapped around an axle around setting the target level. In Rhode Island, we measured, we proved that it was lower than what it should be, and we set the goal as improvement and said, well, we'll worry about an endpoint at some point in the future. And eventually they got there. This may get to what Senator Friedman was talking about with find the right balance between what's in statute, what's in regulation. I think the target level is better set in regulation than in statute. The accountable entity, the discussion is pretty clear. We have to think about plans, but also health systems. And it sounds like Mass Health has done a lot of work around that. We'll talk about that on the next slide. And that's the next frontier. And then I think with CHIA and Health Policy Commission, you have a excellent monitoring capacity. I do think we have to think about the public voice for primary care and what keeps policymakers focused on it, given all the other concerns that are out there, and then prioritize within primary care. I think the task force is a great place for that to happen. We did not have that in Rhode Island. They don't have it in Oregon, and they suffered as a result. State needs an external partner to stay focused on these sorts of issues, to be learning and keep it as a priority. Next slide, please. The last two are, how do you get to systemic impact? It's clear, Ryan was talking about this, you've got to get enough payment to make a difference for primary care practices. When you talk about primary care spend, I think that means getting commercial insurance, the connector, Mass Health, and the GIC aligned and working in the right direction. I think you have an excellent chassis with Mass Health and the work that's been done there. It's delivering results in terms of changing the primary care spend measure in a way that's not happening in other places. There will be always, we will never get to the perfect, and I would encourage folks not to let the perfect be the enemy of the good. As you get aligned, then you can look for Medicare opportunities. And then we spent a lot of time talking about this depth. How do we know that it's making a difference? I called out the work that CHIA and HPC have done around measuring total cost of care and empaneling patients. It's from what Ryan contributed in the discussion so far, it sounds like there's a lot of work that's being done in Mass Health, which I apologize for not calling out here. But again, that's a place to learn, kind of V1.0 as he talks about. But I do think we're going to have to go beyond claims to financial reporting. And that sort of oversight, given the fact that these systems are consolidated, they have enormous market power. We have an interest in their solvency, but we also have an interest in making sure that their finances are adequate but not excessive. And then we have to think carefully about enforcement, just like you are around healthcare cost growth targets. And then my last slide is just sort of the longer run here. The reason why we're talking about this is that we have an out of balance healthcare delivery system that is bankrupting our country. This is why we're doing this work, and it's harming our aspirations. This is a battle that's being fought in Congress as we speak, where we cannot have 25% of our federal budget going to healthcare if we want to have money for tax cuts, for energy credits, for people's wallets, wherever else we want to put it. And the question for all of us is, are we going to keep everybody in the boat when we start to look at the excesses of our healthcare system? And I think Massachusetts has made a strong argument that primary care should be a priority for this work. That means understanding the economic and political forces as you're doing through your HPC process. And I'm here to say, I guess, that putting a thumb on the scale for primary care by emphasizing increasing primary care spend is a high leverage way to begin rebalancing the delivery system. So that's the case for primary care spend as a key target for this work around rebalancing our health system. Thanks very much. And we've got 15 minutes for questions, it looks like. So I'll run the conversation until David and Kiame intervene. Yeah, Wayne.
Sorry, Wayne, you're on mute. Start over.
Sorry about that. So thank you so much, Chris. Chris is legitimately the OG of increasing primary care spend. He and I have talked about this spend versus investment argument, and I think you make a great point. One of the other things you've said when we've talked about this, Chris, is that no other aspect of healthcare is imposed to deliver a return on investment. Only primary care seems to have that imposition. That said, it's also the only part of healthcare that can deliver that return on investment. So while I don't think we should be burdened with that, I think the flip side of that is that we have the opportunity to deliver that, and that's an important part. We kind of want to be able to say we can, but don't expect us to. I love the part of your presentation, or that the essence of your presentation was learning from other states. You talked about Oregon. In Oregon, They also shifted their denominator, as you said, to a very broad denominator. And from what I've heard, their numerator and the amount that they actually increased on spend in primary care was insignificant because of the way they shifted their denominator and made it broader. So that's a problem. You talked about how in Rhode Island, it didn't include ERISA plans. I believe Delaware has suffered from the same fate. So people like to talk about being incremental, but if we're incremental and we lop off, huge percentages of the state from being included in the legislation, then it will be too anemic, and all this work will have gone for naught. I think if you were to grab 100 PCPs in Massachusetts and 100 PCPs in Rhode Island and try and assess is there a significant difference in how happy they are in primary care, I don't think there would be a big difference. I think you spoke to that in your comments, and I would suggest that perhaps a big reason for that is that only about 20% of the state was included if you didn't include ERISA plans, and that's the same thing I fear for Massachusetts. I love the fact that you said competing with California. I remember last year when the Celtics were in the championship against the Mavericks, Mayor Wu made a bet with the mayor of Dallas about who would win. Of course, Mayor Wu won. And what I would say is, why not have Governor Healy make a bet with Governor Newsom, see who can get to 15% primary care faster? I love that idea. Speaking of California, I was at a primary care summit on the West Coast. Kevin Grumbach was there. And Kevin spoke about all these different states and all the things that you were talking about. And his conclusion was that all of these different states have a fatal flaw. Renee was talking about how California, it's 15%, but it's aspirational. There's no teeth there. And he said all of the different states have a fatal flaw except for Massachusetts because of the Primary Care Stabilization Fund. And as Barbara Spivak was talking about, extricating primary care from insurance and creating its own system. And you're right that people are looking to Massachusetts. We've had folks from 10 different states reach out to our Primary Care for You team asking to learn more about what we're doing in Massachusetts with Primary Care for You to incorporate it into their legislation. The last thing I'll say is that I know you have this fear about primary care going the way of public health, but if we have legislated that primary care spend has to be 15%. That's our protection to prevent that from happening. Thanks so much, Chris.
Thanks, Wayne. Mark?
Thanks, Chris. Good to see you. And I always learn a lot from every time you speak. This was a wonderful presentation. I just wanted to make sure I have some of the main takeaways down. And you said something that I think is worth repeating. It sounds like for this to be successful, we're going to need to have accountability for payers and health systems alike for the distribution of spending and making sure that it's going to primary care. And also, you said something I think very important. And let me make sure I have this right. Rather than setting specific spending rate targets, to set improvement targets. Did I have that correct? And the reason I want to kind of emphasize that is because that will actually deal maybe quite effectively with a concern I raised earlier about different payers and different providers having very different patient populations who are going to have a natural starting point that's a lot closer to a fixed numerical target if it's not stratified. And the reason for that is if we were to set a 15% spending target and our children are already kind of close to 10%, which wouldn't be a surprise, just based on research you sponsored originally 10 years ago that we completed. Pediatricians are going to stand to gain a lot less than general internists from this kind of fixed target. And I think that's the kind of thing that would be an unintended consequence of sort of the technical details here.
That's correct, Mark. And there are also political or practical ideas or advantages rather to setting an improvement target rather than an absolute attainment. A lot to be learned from quality measures and how we've learned how to set those. But yeah, it's and I think if you set it as improvement and you leave it to a regulatory function rather than a statute, then you can have a discussion about at some point maybe you do transition to an absolute, but not right away. And if you take on the absolute too soon, then we're frankly going to get tied in a knot around what those should be, and you're going to have the inequities that you cite because you've got to adjust it for different populations. So yes, you heard. I appreciate your emphasis. Let the minutes reflect. Eric.
Awesome presentation, Chris, and I love the last line in your slides. We got to put a thumb on the scale for primary care, and I couldn't agree more. That's the only thing that's going to change this over time. So recognizing that systems are different, right, in terms of the population of patients, do you think if we were to move Medicaid rates up to Medicare and then set a commercial floor rate so that the high cost systems didn't get just higher? Because if we say everybody's going to double their primary care rates on the commercial side, that's going to really help some systems, but do very little for the safety net systems. So bring Medicaid up to Medicare rates and set a floor at 250% of Medicare for fee-for-service rates for primary care. Is that a kind of a reasonable, simplified model? Do you think that that would have any impact given all you know about these different complicated systems?
I certainly, Medicaid versus Medicare. I think in general, I mean, this is I live in foundation land, so it's easy to talk about how things should be, but enormous variations by payer type and what you as a provider get paid are bad policy. It creates cross subsidies. It creates all sort of gaming. So the closer you can get to having payers pay similar things, that's a fairer, it's a simpler process. I don't know what the absolute amounts are. I think, I don't know where Mass Health is in their subcapitation related to Medicare right now. But I will say, outside of primary care, there's increasing attention. Commercial guys, this might be a little bit off topic. Commercial employers rather, are recognizing that they're getting fleeced by large systems and that they're paying enormous markups compared to Medicare, and they're starting to put pressure on it. You're seeing reference pricing bills all over the place. So why shouldn't we start thinking? I mean, I would be careful. And there's a lot of data that says Medicare is an underpayer for primary care relative to other places. So I would. Medicaid equivalence to Medicare is only the beginning. I would think we actually want to go a little bit above because we've been pressing Medicare to increase what they pay. But in general principle, using Medicare as a reference is not a bad idea. I wouldn't say 100% of Medicare. I'd try to get frankly, a bit above that and putting some downward, reducing the cross subsidies is what I'd say.
And maybe a cap and a floor on the commercials.
Yeah. Renee?
Again, thank you, Chris. And sort of piggybacking on what Eric was talking about, we do have some legislation before the state regarding increasing the commercial rate for FQHCs, and that's also included in 3 of the primary care bills, including the ones that Wayne is talking about. I will say that one of the challenges is, yes, we need improvement, but we also need a threshold. And everyone has to meet that threshold, and then we improve. Because I think one of the things I'm commonly hearing is the understanding that the first part of the algorithm is increasing, whether you call it an investment or a spend in primary care. That is the critical factor. And I think the fact that everyone keeps bringing up, we have so few health systems in this state, and if they don't feel they have a vested interest in primary care getting better just because it decreases morbidity and it decreases mortality, if they don't feel that that's a significant enough reason to invest in primary care, then yes, one of the biggest things we have to do is make it really clear that there will be more money being put into primary care. And how that flows after it's entered, that can be addressed by competitive forces. And one of the things that I'm going to continually put up is the more we simplify the way that we do billing in this state, the more that independent practices and smaller practices can have smaller financial departments, reduce their expenses, and that part of the operating margin is going to have a larger impact. If we can reduce the fixed costs, so a part of our legislation, a part of our, whether legislation or regulation, I do like how you divide it up, is we have to find a way to make it easier for people to engage in the billing process. Because if you're spending 5% of your revenue just on doing the billing process, none of that's going towards clinical care. So I do think that addressing things from both the expense and revenue side is going to be critical. But the number one thing is clearly saying that we have to have a threshold that everyone has to meet. We must increase the primary care spend, whichever one of the bills. Your
Well,
thoughts, Chris?
I see Brendan with a hand raised. I know we're getting close. I would say you've shown that you can Massachusetts have shown that you can measure. It's relatively easy to set targets. I would encourage you to think about enforcement and consequences. You have an enforcement mechanism with in your rate review authority, and you've talked about enforcement for some of the cost growth targets and the notion of penalties or improvement plans with the your overall cost growth targets. But think of as you in that scenario that you set out, Renee, think about enforcement, because that's targets are just not sufficient. That's the bottom line. Yep. Brenda?
I'll be really quick. I'm representing the pediatricians with acknowledgement that our family medicine colleagues also take care of pediatric patients. And just with your Rhode Island experience, I'm curious, given that they recently passed some sort of Medicare parity with Medicaid, Medicaid parity with Medicare, even though that's not sufficient, but it's a base. And this also primary care spend dollars. I was curious if you had any thoughts of how sort of jointly that would work out.
Not great, I think, and pediatricians have not been well served as a group in Rhode Island, or they haven't gotten sufficient attention on the primary care spend, in part because so much of their population is covered by Medicare, 50%. And so I think the pediatric dialogue, wherever in any state, frankly, needs to focus particularly on Medicaid, because Medicaid is just, it covers such a significant portion. And I can't speak to in Mass Health subcapitation payment, how that's affected pediatric practices.
Well, everyone, please join me in thanking Chris again for the presentation and the conversation and the discussion. As I think was said multiple times, every time I have the opportunity to hear you talk, I learn something new, and appreciate the reflections on lessons learned and your, as always, honest and candid thoughts. Will be really helpful for us as we continue the work of this task force. And we know that we can call on you again if we have additional questions or requests for your perspective. So thank you again, Chris.
Well, thank you, Dave and Cami, and just thanks to the committee members. That conversation in the first hour, I asked David if I should come on for the first hour. He said, yeah, absolutely. And it was very instructive to see you guys. This is only your second meeting. This is really hard work, but I'm so impressed with folks' engagement. I would encourage you to stay at it, please.
Thanks, Chris. And just to wrap up the meeting today, as Chris just said, this was just our second meeting, but we are going to keep at it. And so we have a number of meetings scheduled already. Before I show you just the calendar, I just want to remind everyone again that we are putting all of the resources and materials from these meetings on a special dedicated webpage on the HPC website that includes presentation materials, links to videos, as well as resources that have been submitted by you, the task members, as important for consideration in the work of the task force. So encourage other task force members to bookmark this page and to check out these resources submitted. We are keeping this updated on a regular basis. And one of the newest resources that I just wanted to give a small shout out to is the Massachusetts Primary Care Dashboard that is on the CHIA website, and MHQP is a critical partner in developing that dashboard. I think it was just released in the last 2 weeks, something like that.
Last
Barbara.
Thursday.
Okay, even sooner. A great source of information. There's a static PDF as well as an interactive work group. Lots of information and data there. So that is also linked on our website, but also go check out the CHIA website to see that incredible work. And then finally, our final slide here is just reflecting what we have currently scheduled for upcoming meetings. We're going to have 2 more work group meetings before August, as well as an additional full task force meeting in July. Our hope is that and our plan is that would be an in-person opportunity in July to come back together and continue this work. And then also after August, coming back again with a full task force meeting in person on Wednesday, September 17th. So that's what we have currently planned, but we'll be looking to fill out the rest of the calendar and agenda. And again, want to thank everyone. And Kiame, I'll give you the final word.
Thanks so much, David. Thank you again to the Health Policy Commission team that is providing the muscle and the brains behind all of the logistics and organizing. It's a big task. And thanks so much to our speaker, Chris Kohler. As Mark said, it's always such an incredible learning experience every time to listen to Chris present on such a topic. And again, thank you for all our task force members participating today. For the members of the public who weren't able to see the chat, there was sometimes a very spirited exchanges happening in the chat, which goes to show just how passionate and how involved our task force members are. So thanks so much. And for those of you who are in Massachusetts, you know that we have not had a sunny weekend in some time. So we're hoping for this weekend to be sunny, and I hope you can all enjoy it. Take care.
Thank you.